Now I invite Smitha Narayan madam to speak on trabeculectomy.
Good morning, ladies and gentlemen. So today I shall be giving you my take on the procedure of trabeculectomy and how to optimize it. So till about 25 to 35 years back, we had only two surgical options for glaucoma. And that was one, which is the gold standard filtering surgery, that is the filtering surgery of trabeculectomy, and the cyclodestructive procedures. I'm meaning about here in this part of the world, and then the cyclodestructive surgeries. But now we have a large repertoire of surgeries, including, as Sir described about in great detail about MIGS, and cataract surgery is again a type of MIGS, and also the glaucoma drainage devices. So today I shall be speaking on how I use trabeculectomy, or how I perform trabeculectomy. So before we actually discuss about it, let us know about the anatomy of the angle of anterior chamber, especially the gonioscopic view. So you can see this is the gonioscopic diagrammatic view of the gonioscopic appearance of angle of anterior chamber. And the juxtacanalicular layer of trabecular meshwork provides the greatest resistance to the aqueous outflow. So you can see these electron microscopic pictures here. The first picture, this one, this is the picture which shows the normal trabecular meshwork under the electron microscope. The second picture shows how it appears in an acute attack of angle closure glaucoma, and the third one is in a chronic case of angle closure glaucoma. And finally, how the primary open angle glaucoma trabecular meshwork appears. So you can understand the great deal of damage and edema and the resistance which happens to the outflow of aqueous. So the trabeculectomy surgery is that filtration surgery which bypasses this diseased or damaged trabecular meshwork such that the aqueous is able to go from the anterior chamber to the subconjunctival space where it forms a filtering bleb. So before actually we perform the trabeculectomy, we must also be familiar with the anatomy of the limbus, the surgical anatomy. So if we were to dissect a rectangular flap from the sclera to the clear cornea, we will encounter three zones. So one is the white zone of the sclera, then is a blue-gray zone containing most of the drainage parts of the angle of anterior chamber, and then there is the clear cornea. So this junction between the white and the gray area is the posterior limbus, and immediately anterior to it lies the Schlemm's canal. So when we are doing the sclerostomy punctures during the procedure of trabeculectomy, we should never cross this junction of the posterior limbus. Immediately posterior to that lies the scleral spur. The anterior limbus is 0.5 millimeters anterior to the insertion of conjunctiva. Again, before performing any surgery, pre-op evaluation is a must. If a patient is on anticoagulants, it is best to stop the anticoagulants for about 3 to 5 days, because the blood in the surgical site is the nemesis of trabeculectomy, because it brings forth fibroblasts and that cause conjunctival or subscleral fibrosis, and that prevents the blood from functioning. Giving 2 to 3 grams per kilogram body weight of mannitol, which should be given within 20 to 30 minutes, is a good procedure to bring the intraocular pressure down. Otherwise, there are, especially in cases of acute attacks of angle closure glaucoma, where the intraocular pressure is not controlled because the patient came after quite some time, quite late, then in those patients, somehow there is a sudden shallowing of anterior chamber and there would be difficulties in performing the surgery. Look at the patient so that you can understand how the prostaglandin associated periorbitopathy causes a very deep superior sulcus, and therefore you can anticipate the difficulty in performing the surgery. give an anti-glaucoma medication drug holiday by prescribing the patient tab Diamox, that is the acetazolamide, for about 10 days or 2 weeks prior to surgery. And you can also use topical steroid drops, FML drops or prednisolone acetate drops, but remember, keeping in mind that these steroids themselves can cause a steroid-induced glaucoma. Then choose the surgical site, and that is best. Though trabeculectomy is best done at the superior position, which is slightly staggered superior nasally or superior temporally, this allows the aqueous to flow down equally in both directions. And also, if you are to perform a trabeculectomy subsequently, this will allow you to have enough space for a second trab or placing a glaucoma drainage device. Avoid the inferior position because that is the place where infections are more likely to occur. As I have shown in this video, check the mobility of the conjunctiva, and that can be done by using a bud dipped in proparacaine, and you should see that the conjunctiva is mobile. Conditions like previous cataract surgery or pterygium surgery, you may find that the conjunctiva is adherent and that discovering it on the table is not a good idea. I usually prefer a subtenance anesthesia because it can be reinforced more and more. People do give peribulbar anesthesia, but with peribulbar anesthesia, you must be careful not to give adrenaline and also not to give a pressure post anesthesia. Many people prefer to do with topical anesthesia. The exposure for trabeculectomy can be best provided nowadays. I use the corneal traction suture using the 80 vicryl on a spatulated needle passed through about 90% of the depth of the cornea, because that gives you an atraumatic field. But the best option, it seems, is the Ong speculum, which prevents the movement of the eyeball and gives you a very good exposure. Previously, we used to use the superior rectus bridle suture, but again, that would bring blood to the surgical site and again would cause the trabeculectomy to fail. I prefer to give injection mitomycin C, about 0.1 milliliter of whatever concentration I have shown here, depending upon the severity of glaucoma. It is given about 8 to 10 millimeters from the limbus, avoiding the insertion of the superior rectus. Then I use a bud to spread the drug mitomycin C towards and away from the limbus and towards the sides. A peritomy can be performed using, I prefer to use a Vanna scissors and an atraumatic forceps like the Pierce-Hoskins forceps. I do not use the LIMS forceps because of its tooth nature. About 5 to 6 millimeter of the conjunctiva is cut. Avoid excessive manipulation or buttonholing, and then I close the blades of the Vanna scissors and then dissect under the incision in all the directions possible, so as to allow for the mitomycin C, to act, especially if I am using sponges. The incision of the conjunctiva can be either a fornix-based incision or a limbus-based incision. I personally prefer a fornix-based incision, though intraocular pressure control is equivalent in both these techniques. The fornix-based incision takes less time to close and is less likely to need an assistant, and it also gives us a diffuse and low bleb. Hemostasis can be performed using minimal cautery because over-enthusiastic cautery can lead to scleral shrinkage. So in all these situations where you are injecting mitomycin C or where you're giving subtenance anesthesia, a drop of brimonidine would be very useful because it will shrink the blood vessels and you can then avoid the blood vessels and give injections, preventing the bleeding. As far as in cases where you want to apply the sponge, after making the peritomy, you can use sponges dipped in the required concentration of mitomycin C and again kept for the required duration, about 2 to 3 minutes. It is very important that the number of sponges that you put inside should be equal to the number of sponges you keep out, because you don't want to retain small fragments of sponges or the sponge itself to cause scleral melting. The sponges can also be soaked in trypan blue for easier retrieval, and since they are biohazardous waste, you should take proper precautions to dispose them. And after removing the sponges, then you have to irrigate the area with about 15 to 20 cc of balanced salt solution. The Injections, I feel, provide a precise control of the dosage of drug that can be given in that area, which is not only safe and effective because it gives there is a lesser risk of losing sponges or sponge fragments, and that gives you a perfect bleb, which is avascular with numerous microcysts, and it is usually associated with good control. And besides, naturally, injections take less time. Then the step of scleral dissection. I usually make a 4 to 3 millimeter size rectangular flap. You can have a rectangular or a triangular or a trapezoid flap, that is your choice. But finally, the geometry doesn't make much of a difference. The dissection should be even. The partial thickness scleral flap that is created should be, I use a crescent blade, but the important thing is that the undersurface of scleral flap should be as smooth as possible, because otherwise, if it's a rough surface, it will promote fibrosis. The sides of the flap are cut 1 millimeter from the limbus according to the Moorfield safe surgery technique. So that allows for the posterior flow of the aqueous, and therefore we get a low bleb. And some of the people prefer to give an intrascleral application of mitomycin C. I used to do it, but I don't think that makes a big deal of difference. The next important step is the paracentesis. A side port blade or an MVR blade can be used to perform a paracentesis about 45 to 90 degrees from the main trabeculectomy site. This not only allows for a gradual decompression of the anterior chamber, it allows also for the various instrumentations which can be, or drugs which can be used to keep the anterior chamber maintained. And it should be created in a self-sealing fashion. Then we come to the main portion of trabeculectomy, and that is the sclerostomy. So that before that we have to enter the anterior chamber, and I usually use a keratome to enter the anterior chamber. That keratome I usually enter in the clear cornea. So that is why knowing the surgical anatomy of the limbus is very important. So once you enter the clear cornea, then you can use the Kelly sponge or the side port blade for performing the sclerostomies. And the sclerostomy should be of sufficient size, but leaving about 1 millimeter on either side of the ostium, so that the flap completely covers it. And very importantly, the anterior chamber should not shallow at any stage during the sclerostomy. Sometimes, if you are anticipating that there would be a risk of any of the serious complications of trabeculectomy, it is best to put a pre-placed suture. Iridectomy is performed using the Vanna scissors and the iris forceps kept at 90 degrees to each other. And iridectomy opening should be larger than the sclerostomy opening. The flaps can be sutured by multiple ways, like the fixed sutures, releasable sutures, or adjustable sutures. I use the 10-0 nylon where the knots are buried. This is the technique of releasable sutures by Kolker's technique. And finally, the conjunctiva is closed with the same suture which was used for corneal traction, and that I use 2 wing sutures, which is vicryl, and then a central mattress suture. And I usually prefer that the conjunctiva overrides over the cornea, so that later on, even if it recedes, the wound is well covered. So I conclude by saying that trabeculectomy is just a basic step. It is the post-op control of the patient which is the most important. Thank you very much for your kind attention.
Thank you, madam, for that very informative talk. We are overshooting time, so I